This is Dr. Feast Price, and I will be providing a lecture on diagnosis, assessment, and treatment planning. For the first part of this lecture, I will focus on diagnosis and assessment, and for part 2 of the lecture, I will include information on treatment planning, but also include information relevant to the termination and follow-up process of working with someone with a mental health diagnosis. Making a diagnosis for someone with a mental disorder is where the rubber meets the road in terms of what we do as clinicians. And there are times when we encounter or interact with a client with a mental health issue that it's very apparent what their diagnosis is. So, for example, if a client comes in and he or she is crying and they tell you that I'm depressed as a result of what I'm going through, I haven't been able to get out of bed, I haven't been able to eat or sleep, the things that would typically give me interest or pleasure or of no longer important to my life. And so those kinds of descriptions make the mental disorder far more apparent. And so we would assume, based upon the description that the client has provided us, that the person is experiencing depression. But there are also instances when we as clinicians must use various forms of tools to help us arrive at a diagnosis for a client, because sometimes the issues that the client is going through are not as apparent and the client isn't as able to communicate what the problems are and what the issues are. And also there are times when clients might convey that there are specific kinds of issues that are going on, and through various forms of clinical assessments, we recognize that there are other issues that might supersede the more apparent kinds of issues that the client present with. So it is in those instances where clinicians must use various forms of diagnostic tools to arrive at the diagnosis that I'd like for us to spend some time and better understand the services that must be rendered when we encounter such clients. So when clinical assessments are needed in order to arrive at a diagnosis, there are decision trees that must be taken into consideration. And Appendix A of the DSM-4 TR, in the back of the book, you'll find in the appendix various decision trees that help you to arrive at the specific diagnosis that best fits with what the client is going through. Your book, the DSM-4 TR, includes 6 decision trees to facilitate the process of diagnostic discrimination. And each tree consists of a series of boxed descriptive statements that act as a yes or no question. And so in order to use these tools, the clinician begins at the upper left box in each decision tree and then follows the arrows to determine the responses that are most consistent with what the client is expressing. And so the 6 decision trees include issues related to mental disorders that are due to general medical conditions, substance abuse or substance-induced disorders, psychotic disorders, mood disorders, anxiety disorders, and somatoform disorders. I'd like to just take a few brief minutes to describe these 6 areas associated with the diagnostic decision tree. So when we look at mental disorders due to general medical conditions, this tree lists mental disorders that are caused by a medical issue or a medical condition. And so oftentimes when persons experience various forms of medical conditions, it is not uncommon that there are mental issues associated with them. With regard to substance-induced disorders, this tree includes disorders that are a direct consequence of drug or alcohol use, such as substance-induced sexual dysfunctions, as well as substance withdrawal. So the tree does not include substance dependence or substance abuse. However, there are additional kinds of issues that accompany some of the substance abuse and substance dependence that are most likely to surface with this particular decision tree. And then there are also psychotic disorders, which includes schizophrenia, schizophreniform disorder, schizoaffective disorder, delusional disorders, brief psychotic disorders, and other disorders that entail loss of contact with reality. And so all of these are included in the decision tree. I encourage you, as we're going through this information, to take a look at the decision tree in Appendix A for the DSM-4 TR. You'll find that it makes far more sense as I'm discussing it if you can follow along with the decision tree that is in Appendix A. The next disorder is mood disorders. And for mood disorders, this tree encompasses major depressive disorder, dysthymic disorder, bipolar 1 and 2 disorders, cyclothymic disorder, and all categorized by depression, irritability, expansiveness, and or an elevated mood. And so these are among the issues that are most relevant to mood disorders when we are working with persons that present certain kinds of mental health characteristics. And next, there is anxiety disorders. Anxiety disorders include panic disorders, agoraphobia, specific and social phobias, PTSD, acute stress disorder, obsessive compulsive disorder, generalized anxiety disorder, separation anxiety disorder, and other disorders with anxiety, fear, increased arousal, and avoidance as their hallmarks are included in this tree. And lastly, we have somatoform disorders, which are disorders characterized primarily by physical complaints that do not have a verified medical explanation. However, they include the somatoform disorders. So it might include somatization disorder, conversion disorder, pain disorder, hypochondriasis, body dysmorphic disorders. These are all included under somatoform disorders. There are also factitious kinds of disorders, psychological factors affecting medical condition, and other disorders and conditions. Although physical complaints may produce anxiety, when the physical complaints are the person's primary concern, this tree, rather than the anxiety disorders tree, should be the one that is most relevant and the one that's used. I encourage you to sit with your DSM, flip through, look at various diagnoses that are of interest to you. You'll learn an incredible amount about disorders because it's not a simple process in assigning a diagnosis to someone. It's actually a very complex process with lots of different criteria that one would have to subscribe to. So I encourage you to sit with your DSM in order to get a better idea and understanding of some of these disorders and how they relate to one's physical functioning, as well as their physical limitations. So although the decision trees are very useful, they do not include all mental disorders. So there are times when you have to have a more comprehensive approach to diagnosis in the use of various forms of questions. And so here I have for you 4 key questions that must be taken into consideration when trying to understand the mental disorder that a client is presenting. The first question is, what are the primary symptoms? And this question should be answered in non-technical terms, with technical symptoms including anxiety, depression, acting out, excessive consumption of alcohol, medically unverifiable physical pain, or pervasive kinds of dysfunction. And so you just want to step away from the situation and ask yourself, so what are some of the primary symptoms that the client is conveying to you, as well as those symptoms that are apparent to you when you encounter and observe the client. The second question pertains to what is the appropriate duration of the disorder. We all know that in everyday life, there are things that happen to all of us. And to figure out if what the client is presenting is normal or within normal limits, or if it's excessive in some way. And so when you ask the question, what is the apparent duration of the disorder, responses might include a number of days, weeks, months, or years, or indicate that the disorder is of infinite and long-standing duration. But once you get an understanding or a perception as to whether what the person is experiencing within normal or abnormal limits, it gives you information that can be used in order to best figure out the best course of treatment for the client. Number 3, how severe are the symptoms? It's important that there is an assessment of the severity of the symptoms. And oftentimes, in order to determine the severity of the symptoms and to understand it from a broader context, you have to look at the global assessment scale that pertains to Axis 5. And so the global assessment scale of the MMPI provides a lot of useful information that gives some verbal descriptors rather than just numerical ratings. Because, at the end of the day, numbers are great, but you need to give specific detail and content relevant to these numbers. And so in instances like that, you want to pay particular attention to the verbal descriptors of one's behavior. And the global assessment scale, which is the Axis 5 of the MMPI, the DSM, gives you relevant information. It allows you to assess the severity of what the person is presenting, identify different kinds of personality characteristics that might also be associated with the diagnosis, or some of the characteristics that the client is presenting. And number 4, the fourth question is, has a specific cause or precipitant for the symptoms been identified? You always want to understand not only when the symptoms occurred, how long they've lasted, but also what brought on the symptoms. What was that straw that broke the camel's back, if you will, or what was the tipping factor that resulted to all of the manifestations of, the mental illness. So you always want to understand whether or not there are specific factors that caused or precipitated the symptoms to occur. So basically, the key thing that I'd like for you to take from the discussion that we've had on the 2 slides that we've just gone over is that, number 1, the DSM is a very useful resource in helping us to identify a diagnosis of a client that comes into our office when the symptoms are not apparent, when it's not evident to us as clinicians what the issues are. The DSM is an excellent tool that allows us to understand what possible issues might be going on with the client. But we also must recognize that the DSM serves as only one tool in order for us to arrive at an appropriate diagnosis. And so in addition to the DSM, there are these 4 critical questions that must be answered in order to help further our knowledge and understanding of what the diagnosis is. But the third piece of that is you, the clinician. It is really important that you, the clinician, ask these, very important questions, and that as you ask the questions, the information that you get, whether it be from the DSM or from, the answers to the questions for the diagnosis, you always have to be conceptualizing and making sense of the information. And that's where it's important that you have a strong knowledge base. It's not good enough just to rely on the DSM, but that you have the ability to take in the information, conceptualize it, and make sense of it, and then to ask yourself, does this diagnosis make sense? Because sometimes a diagnosis may make perfect sense based upon the DSM, but then you can think things through very critically and realize that while it makes sense in the DSM, it doesn't fit with some of the other things that you're perceiving with the client. And I'll just pause a little bit to tell you about an experience I had when I was working with a client in the federal prison. I was working with this gentleman who had never displayed any symptoms associated with having an Axis 1 diagnosis of schizophrenia. But there came a time through my interactions with him, he started exhibiting what would be diagnosed as schizophrenia. He was hallucinating. He wasn't in touch with reality. They put him in segregation confinement. They said that he was smearing feces all on the walls. And of course, the many clinicians were saying that he had schizophrenia. But my gut level reaction was saying, well, how can he have schizophrenia? This is a 55-year-old male who has never had any diagnostic assessments that said anything about having schizophrenia. And I had also encountered this gentleman for months without there being any indication of him having schizophrenia. Through my persistence and wanting to try and arrive at what else could be going on, I learned from someone that if a person has a urinary tract infection, it can provide symptoms that are consistent with psychoses. And so the person was then moved from segregation to the hospital. His behavior was really out of control. They saw that his behavior was deteriorating. And while he was in the hospital, because he wouldn't take some of the other forms of medication that he was under for hypertension, he became paranoid and was suspicious about the medication that was being given to him. But while he was in the hospital, I said to my supervisor, is it possible that they can test him for a urinary tract infection? Because I've been told that a urinary tract infection can provide manifestations that are consistent with having an Axis 1 diagnosis of schizophrenia, even when the person isn't. And lo and behold, wouldn't you know it, the assessment that the doctors conducted in the hospital to determine whether he did in fact have a urinary tract infection came back positive. And what that said to me at a very early point in my career is that while the DSM proved accurate in terms of the criteria that the person met, with the exception of age, because he didn't meet the age criteria. So he probably could have been ruled out because of the age factor, because typically when a person is diagnosed with schizophrenia, particularly men, it's between the ages of 18 and 24. But you always have to dig deeper. You can't just rely on one source of information. So the DSM is a wonderful tool. You have to ask critical questions, but at the end of the day, you cannot be so busy that you don't take a step back, think critically about the information you're getting, as well as what is communicated through the client, both verbally and behaviorally, to arrive at what the appropriate diagnosis is for the symptoms at hand. And it's only when we can appropriately diagnose the symptoms can we appropriately treat the symptoms. So consistent with diagnosis, there are times when we have to use various forms of assessments and diagnosis and treatment planning. I talked with you about the gentleman that displayed symptoms of a urinary tract infection. The appropriate assessment in that instance was having a urologist run whatever the screenings were to assess the extent to which there was some medical kinds of issues going on. And so assessments are always very, very important in helping us to identify what some of the key issues are that are manifesting itself in working with clients, because they're not always apparent in observations, and it's not always communicated to us through our clients. So we use various forms of assessments in the diagnosis and treatment planning process in order to effectively diagnose a disability in order to meet the needs of our clients. So when we talk about diagnosis, the meaning of diagnosis is to know the client in terms of both internal and external perspectives. And the process of diagnosis can be approached in a comprehensive way that enables counselors to develop a good understanding of people and their environment, and through the process of assessment, formulate a diagnosis and treatment plan, as well as enhance the counseling relationship. And so it is through this process that we can meet the needs of our clients and help them to move from where they are to where they need to be. So conducting an effective assessment is a structured process, and it can occur at several different points in the counseling relationship. Although ongoing assessments is also inherent in effective counseling. So assessments can occur at the beginning or the onset of counseling, mid-counseling, as well as toward the end of the counseling experience. And so when we begin the therapeutic process, some sort of assessment almost always occurs at the onset or outset of the counseling process. And it typically might include an initial intake, interview, and sometimes it can occur in the format of psychological testing so that the initial diagnosis and treatment plan can be developed. So structured assessments they can also be done later in the counseling process. So midway the counseling process, one might choose to do an assessment. And so mid-counseling assessments may be global. It can be a way to provide an overview of the client's development as well as their level of function, or they may be specific in terms of determining whether the person has changed from the beginning of the counseling process to the middle of the process. So for example, if at the beginning of the process you do an assessment to determine their level of depression, so you might use the Beck Depression Inventory to assess their level of depression at the beginning of counseling. Mid-counseling, you might do a follow-up assessment of depression to see if their depression has lessened at all. And then at the ending of the therapeutic process, then you would continue with the assessment in order to determine if the client has attain the goals that have been set for them at the onset of the therapeutic process. So this information gives really, really important information about where the client begins the process, but also it helps you to assess the progress that is being made. And I find nothing that's more rewarding to a client than to say to them after they have begun the process that when you initially started counseling, this is where you were. However, today, this is where you are, which is evident of the progress that's being made. That's very affirming to the client to have that information. they see that they're growing and evolving as a result of the hard work that's being done in the therapeutic process. So assessments have 4 primary purposes, and it includes the classification of information, evaluation, selection, and prediction. And so just to unpack each of these different assessment purposes, classification as well as evaluation generally are the most important as the counselor explores the cognitive, behavioral, emotional, interpersonal, and environmental aspects of a person, and it classifies their feelings according to certain frameworks. So initially, at the very beginning, you want to evaluate and classify what a person is feeling, and you want to classify this information based upon either a psychosocial, a biopsychosocial framework. Sometimes it might be based upon the DSM. It might include some of the developmental stages that the person is going through. We've talked about in the Theories and Techniques counseling course, we've talked about the stages of change, and so you can also classify where the person is through the stages of change process, whether or not they are ready to change, or whether they're still pre-contemplation, or whether they're contemplating changing. And so it's important to understand where your client is in the stages of change process. So always evaluation and classification are very, very important in understanding where your client is and their willingness to move through the therapeutic process. In addition to classification and evaluation, there is also selection that goes into the assessment process. So it's also important to select the therapeutic programs that are most important for your client to move them through the therapeutic process. And so it might include counseling groups, it may include individual therapy, it might include them being involved with some of the community-based services and support groups. And so it's always important to select the most effective treatment tools that are needed to help the client move through the treatment process. And then prediction includes the likelihood of events such as the person's succeeding in a particular educational program or engaging in the treatment process. So prediction allows you to determine the extent to which the client will benefit from the identified treatment modalities that are put in place. And from the clients I've worked with in terms of prediction, one of the ways that I use to predict the success of a client has to do with whether they come in voluntarily or involuntarily. When we talk about the stages of change model, if a person is ready to change, they're most likely to change. If a person comes in because they're forced to come in, like for example, as a result of drug court mandates, or they're forced to participate in a group, a therapeutic group, because they want to stay out of jail, but they really are not ready to give up their involvement in substance use, that oftentimes determines the level of success that you might have with clients. I also know from working with persons, particularly that are forced into treatment through drug court as well as through substance abuse mandate programs, that there are times when people might begin the process and they're very apprehensive. They come in and they're like, you know what, I'm just going through this because I have to be here. I don't expect to get anything out of it. I don't believe that I'm a change. This is, a lot of times they'll tell you this is BS. But then lo and behold, as they sit through the process and they listen and they engage in the learning, you could see their wheels are turning. You could see that they are contemplating the relevance of what they're hearing. And then there are also instances where people actually change despite their intent initially to remain where they were when they came in, and that they would get nothing out of the therapeutic treatment process. So it's always important, even though you make predictions, never give up on your clients, because you never know that through the therapeutic process, they might be so inclined to change their behavior in ways that they never intended on it. Therapy is a very, very powerful process. All it takes is a willing vessel. And even in instances where people are not willing, when they come because they're forced to, I have seen profound changes through people who come not willingly, but because they have to come, they end up benefiting. So always do your best work, because you never know when people will catch on and be so inclined to make positive changes in ways they never thought they would. So assessments can enhance the counseling process in a lot of different ways, and so it is most beneficial to the therapeutic process, the counseling process. And so I'd like for us just to talk about some of the ways in which assessments can benefit the counseling process. And there are a total of 20 items that I'd like for us to discuss and unpack. You see the first 10 here. On the next slide, you'll see the remaining 10, each of which I think are very, very important in working with our clients, because not only is it important in moving through the counseling process, it also helps to affirm for the client that they have the skills and abilities to make life changes. So the very first thing on the benefits of assessment is to streamline and structure the information gathering process. And that's what one of the primary things that assessments will allow us to do, to streamline and structure the information gathering process. Secondly, it allows us to enhance the credibility and validity of that process. Clients don't always come in convincingly. They don't always believe in the process, but assessments give clients credibility, and it serves to validate that they really are changing. And I think nothing does that more than to give them an assessment inventory at the beginning, like I mentioned the Beck Depression Inventory. So at the very first session, at the onset, you might do the inventory. Mid-session, you do it again. And so then you go over where they were when they came in and where they are midway through the treatment process. And it really gives a lot of credibility to themselves as well as to the treatment process. Most of the clients that I work with are as a result of referrals. It's as a result of people saying, you know what, I had this awesome therapeutic experience and I recommend it to you as you're going through whatever this troubling time is. And so not only does it give the individual the credibility in believing in the process, but it also helps them in sharing that with other people who are less likely to come to therapy. And you find that a lot in certain cultures where they don't view therapy as a viable option, but when they have a family member, a friend, or significant other who has gone through the therapeutic treatment process and they have credibility in what they've experienced, they give credibility to it, which encourages the likelihood that other family members, friends will also seek the necessary help to live full lives. So that's number 2, enhancing the credibility and validity of the therapeutic treatment process. So number 3 talks about the fact that assessments assess and promote motivation toward positive change and client-counselor collaboration. So it's really important to not only assess where the person is in terms of their stages of change, but to promote the continued movement through the change process. Number 4, identify and measure the severity of people's symptoms and assess changes in those symptoms. That's always important, and we talked about that as we talked about the Beck inventory at pre-test or at the beginning of treatment as well as mid-treatment. Number 5 speaks to promoting insight into a person's self-concept and self-esteem. That's another benefit. Number 6 is to clarify whether pathology is present and to help determine the client's diagnosis. 7, identify intellectual and academic strengths and weaknesses, as well as to learn to understand their different learning styles. At times we have to tailor our learning style based upon the person. So figuring out what the learning style is so that it's best suited for the persons that we're working with. Number 8 talks about clarifying leisure and career interests, needs, and values. I'm sure you're aware of interest inventories and interest assessments that helps to clarify the leisure and career interests of our clients, as well as their needs and their values, whether they're a people person or introverted or extroverted, taking in all of those various kinds of factors into consideration when helping persons to identify career goals and aspirations. Number 9, to provide information on personality, style, affect, interpersonal skills, as well as overall personal strengths and difficulties. And so sometimes there are these personality inventories that we give in order to understand their personality style and ways of assisting them in maximizing their potential. Number 10 talks about assessing and quantifying habits and behaviors. Sometimes it's important to assess how often something is happening, a particular behavior is being exhibited in order to determine whether or not it is a problem. Hand washing isn't a problem, but if you're washing your hands 50 times a day, then that can be a major problem. So assessing the quantity of, to assess and quantify the habits and behaviors is really important. Number 11 speaks to translating interests, abilities, and personality into occupational terms. And that's an important skill and attribute that we have as rehabilitation counselors, by way of allowing people to identify their interests. I think of Holland, the Holland interest inventory that allows us to match one's interests with various forms of occupations, which shows that they are more likely to enjoy their job and be most optimal in their performance. Number 12 speaks to providing information on the environment, the family constellation, social and multicultural background, as well as the context. And so that's always important so that we can understand some of the micro and macro kinds of issues that impact the individual, because that too is very important in working with the individual. Yes, we can focus on the individual kinds of issues, but if there are familial kinds of issues, as well as community and environmental, systemic kinds of issues that impact the individual, they too can limit one's ability to succeed and progress. So we definitely want to understand some of the micro and macro kinds of issues that impact the individual. Number 13 speaks to determining a person's suitability for a particular program or treatment. There's no one size fit all, so identifying the best form of treatment facility in light of what the person is experiencing is very, very important. Number 15 is to simplify goal setting, because most often than not, 3 is the maximum number of goals that you need to have when working with a person. So you definitely want to simplify goals and focus primarily on those issues that are most salient to the client, and also the issues that are most problematic. Number 16, promote more relevant and focused counseling and discussion. 17, generate options and alternatives. Number 18, facilitate planning and decision making. Number 19, indicate the likelihood of certain events, for example, successes in occupational or academic endeavors. There are these instruments that actually are used to determine the likelihood of success. For example, that's the purpose of the GRE, to determine the likelihood of success. So sometimes I look at certain kinds of assessments to determine the likelihood of success with caution, because these instruments sometimes tell us one thing, but it may not always be accurate, and then people change their behavior. For example, I mentioned already, they might start off a treatment program with a low likelihood of involvement, participation, and success, and lo and behold, a switch flips because something was said by either the therapist or members of a group that gets them to think things differently and change a behavior that they swore would never change when they walked into the treatment setting. And number 20 speaks to determining whether and how much progress has been made. And so we talked about assessments that are being done at the beginning, middle, and end to determine the extent of progress that has been made in the treatment process. So these are the benefits of assessment, which are very many. I'd like for us to now focus our attention on some of the areas of assessment. And in talking about these areas, I'd like for us just to kind of go through them very briefly. So the assessment process may focus on any or all of the following areas. And the first is cognitive attributes. And we know that there are assessments that may be comprehensive or specifically focusing on issues related to thinking and learning style, IQ test or intellectual ability kinds of assessments, areas associated with achievement, aptitude, problem solving, and awareness of reality are among the kinds of assessments that might be used specific to cognitive assessments. There are also different behavioral kinds of assessments, and these assessments or inventories look at overall behavioral patterns as well as specific behaviors such as eating, sleeping, substance abuse, attention, violence, assertiveness, communication styles, depression. So there are assessments that are specific to various forms of behaviors. And so I'd share with you some of those. Additionally, there are personality as well as affect assessments. And these assessments may provide a comprehensive picture of personality or assess emotional states and traits such as mood, values, self-esteem, or even anger, depression. So those are some of the different kinds of personality and mood assessments that might be most relevant when working with persons that come to us for treatment. There are also interpersonal relationships and context kinds of assessments. Possible areas of focus may include family background and dynamics, relationship patterns or interpersonal conflicts, as well as strengths. And then number 5, physical or biological attributes. These assessments often assess appearance, size, shape, physical abilities and disabilities, as well as medical conditions. And number 6, social and multicultural environment. These assessments are in the area of socioeconomic level, cultural beliefs and values, support systems, as well as other kinds of variables. So as you can see here, there are all sorts of assessments that may be used to provide us with a wealth of information by which we can better understand our client and arrive at the appropriate diagnosis, which informs the kind of treatment that must be used in order to help them to resolve whatever the limitations they're experiencing. So what's really important here is to understand the importance of assessments in the diagnostic process. Without appropriate assessments, we're very limited in terms of the kinds of treatment that must be provided. So before deciding to use tests or inventories, counselors should ask themselves the following questions, and these are key core questions that Seligman identified for counselors as they move forward in the treatment process. And the very first question that one would ask is, what are the goals of the counseling process? What are you trying to achieve? Number two, what information is needed to accomplish those goals? And number three, have available resources of information such as the client's own experiences and self-knowledge, as well as previous records and tests, been used effectively and fully. No need to give us additional cognitive assessments when within the client's files are relevant assessments that can be used without taking up additional time and resources. So these are all very critical questions, but in addition to those three questions, additional questions that must be asked in formulating the assessment process is, does it seem likely that testing and other forms of assessment will provide important information that is not available from other sources? And what other important questions can be answered by the testing, and how should testing be planned and integrated in the counseling process to maximize its benefits? It's not good just to use assessments just for assessment purposes, but what is important is to have specific kinds of questions that are most important to be used. So counselors should know whether additional information is needed before testing begins. Once you've asked the questions, then it helps you to know whether additional information is needed, especially if the client is being referred for other kinds of tests. And counselors must clarify the reasons for the assessment and communicate them as specifically as possible to the examiner so that the person who will be doing the testing have a clear understanding of what is needed by way of the assessments. And this is particularly likely to yield the needed information. Otherwise, you might find that the person is being assessed in areas that are not providing the most useful information that's needed. So the premise questions, such as the following, are typical for those asked during the assessment process. Does the person have a mental disorder? If so, what is the disorder? Does the person need hospitalization, or is outpatient treatment adequate? What interpersonal patterns seem to determine the person's social relationships? Is this child or adult likely to perform satisfactorily in a regular classroom? And this is particular for children. If you're working with children, is the child likely to perform satisfactorily in the classroom? What is the severity of this person's depression? And what is the person's intellectual level? All of these questions are really important in working with our clients, and sometimes such specific questions can't be formulated because of a lack of clarity about a person's developmental, as it relates to a client's development and difficulty. And in such cases, a general psychological assessment involving a battery of tests combined with an interview is typically used to provide a comprehensive picture of the client. So there are inventories and assessments that provide the answers to some of the questions that we just asked. So there are general assessments for midlife transitions, and these assessments might include, for example, the California Psychological Inventory, the Strong Interest Inventory, the Lifestyle Assessment Questionnaire. These are only a few of the assessments that might be used to assess the midlife transitions that a person might be going through. There are also general assessments that are conducted by a licensed psychologist. For example, the Rorschach test, which is more of a neurological kind of assessment, the thematic appreciation test, projection drawings, the Bender Gestalt, the Wechsler Adult Intelligence Scale, the MMPI. These are all general assessments that are sometimes conducted by licensed psychologists. Then there are assessments of an adolescent with career confusion, and that can include the strong interest inventory, differential aptitude test, career maturity inventories, the Hall occupational orientation inventory, just to name a few. And fourth and finally, there are assessments of a person with significant depression and interpersonal concerns. And among the assessments that are most likely used are the Milan Clinical Multi-Axle Inventory, also known as the MCMI. There's the Beck Depression Inventory that I've referred to earlier in our lecture. And there's also the Myers-Briggs Type Indicator that gives information about interpersonal kinds of issues. So we know that assessments are really important. There are certain kinds of tools of assessment. There are assessments that are qualitative. There are some that are quantitative. And when you look at the quantitative forms of assessments, they may be non-standardized or standardized. So I'd like to take a few minutes just to kind of unpack qualitative assessments and what they entail. So qualitative assessments might include interviews, some of the counselor-made questionnaires. It might include observational kinds of data as well as reports or information provided by others. It might also include autobiographies or life histories, products made by a person that provides relevant information, timelines where the person gives you some indication of when certain things occurred and how their life progressed through time. The client may provide information regarding early memories, some of those early recollections of childhood kinds of experiences. They might provide information specific to daydreams, dreams during sleep, as well as fantasies. So this slide provides just a brief overview of some of the areas that I just went over: the interviews, counselor-made questionnaires, observational data, reports or information provided by others, autobiographies or life histories, products made by a person, timelines, early memories, daydreams, dreams during sleep, and fantasies. So if we just take dreams during sleep, oftentimes people do not give any credibility to dreams that people may share information on. But it's less important what information we subscribe to the dreams. But what's most important is the information that the client is associating with the dreams. And so to ask a client, what do you make of your dream? What relevance is that particular dream to you? And that allows you to understand from a qualitative perspective the relevance of that information. There are the non-standardized kinds of quantitative approaches that are sometimes used by clinicians. And so they might include checklists where a person has to check off certain issues that may have occurred, certain problems, symptoms, or concerns that they may have. They may have a rating scale. For example, I'm able to assert myself with an authority figure, and they might rate it almost always, usually, often, sometimes, rarely. And so rating scales is another way by which you can obtain relevant information. The card sort is one of the ways that allows the client, especially with career planning, to sort out cards that are most relevant to their interests, identify those that are of particular interest, and figuring out what characteristics are most apparent among those issues that of greatest interest to the client. So the card sort process is very important. Rank ordering is also important, and it can help a client to identify goals, tasks, losses, interests in a hierarchical format. So when there are a number of issues, allowing the client to rank order issues of most importance to least importance. And also frequency logs, like allowing the client to tell you through the logging of information how often certain things occurred, how often they're most likely to have these self-deprecating kinds of or self-depreciating kinds of thoughts. So frequency logs is another way to understand non-standardized quantitative approaches. And then, as it relates to some of the more standardized approaches, and these approaches demonstrate some degree of validity and reliability. They have been tested in various forms of research that proves the success over time. It provides more objective sources of information, allows comparison of the client with others, not only by one particular therapeutic counselor, but also looking at a particular treatment approach with other counselors as well. Cognitive behavioral therapeutic approaches are used very widely in terms of the treatment techniques and working with clients. And it also facilitates predictions of success. And it provides access to new information. And so when identifying the most appropriate standardized quantitative measures, there are different types of catalogs by test publishers, as well as test manuals and references that can be used to give you relevant information about appropriate forms of assessments that are quantitative in nature. And some of the resources that you can refer to is the tests in print. There is a publication called Tests in Print that provides you with relevant information regarding standardized assessments. It gives you validity, reliability. It talks about the sample, as well as relevant research findings regarding the assessments. Another reference is Test Critiques. There's also Measures of Clinical Practice. That's another assessment, another tool that provides information on different kinds of standardized quantitative measures. And then there is also the Mental Measurement Yearbook. And these are all manuals that gives you relevant information about standardized quantitative assessment measures. There are also websites that you can identify with just a few strokes of the keyboard to identify tests and assessment tools that are most relevant with strong reliability and validity. There's the Eric Clearinghouse on Assessment and Evaluation. There's the Association of Test Publishers, the Bureau's Institute of Mental Measurements. And so these are three invaluable websites that can provide you with a lot of relevant information about assessment tools that are quantitative in nature. You know, it's impossible to remember all relevant details about the different kinds of assessment tools, but it's easy to just pick up a manual, flip through it, and identify the best kind of either quantitative assessment. And sometimes there's assessments for other the non-standardized assessments as well, but you don't have to reinvent the wheel, and the information is within your fingertips. So basically, this is the end of part one of the lecture on diagnosis, assessment, and treatment. And so the subsequent lecture will provide additional information that will help you to understand the gestalt associated with providing treatment to persons with mental illness. Thank you for your attention.